Welcome to the fourth of our four-part special series focused on obesity. I'm your host, Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. This special edition of Diabetes Core Update is a collaborative project of the American Diabetes Association and the American Academy of Family Physicians and is sponsored by Novo Nordisk and Lilly. Obesity is common. On the first podcast of this series, we talked about the epidemiology of obesity. We talked about health equity, obesity as a chronic disease, and root causes of obesity. It was a fantastic episode. I highly recommend it if you didn't listen to it yet. In the second podcast, we discussed the range of treatments available for obesity, and we went into great detail. Highly recommended. And I also recommend the third podcast where we discussed how to open and have a conversation with patients about obesity. Not always an easy thing to do. In this fourth podcast of this series, we're going to tackle selected challenges that we all face in the treatment of obesity. And joining us to accomplish this, we have two expert colleagues. Dr. Deborah Horn is the medical director for the University of Texas Center of Obesity Medicine and Metabolic Performance and has written extensively on obesity, most recently being one of the primary authors on the very important SURMOUNT-4 trial. Welcome, Debbie.
Thank you, Neil. I'm really excited. It's been a year of tremendous change in treatment, disease states that can be treated, and access in obesity. So this is going to be a fun conversation.
It has been an amazing year. Also joining us is Dr. Robert Kushner. Dr. Kushner is a professor of medicine at the Northwestern Medicine Feinberg School of Medicine. He is the author or editor of 15 books. That is a lot of books, 65 book chapters, and hold on to your seats. Over 200 scientific articles on overweight, obesity, and nutrition. He's been quoted in the Wall Street Journal, Forbes, People magazine, and is the author of the popular book, 6 Factors to Fit. Bob, it's a pleasure to have you join us again.
Neil, that was very kind of you, and it's a pleasure to be here along with you and Debbie.
Let's start with the basic question that we all face all the time when a patient comes into us for help with weight management, and that's deciding between the options that we now have available. One option is lifestyle, that's advising people about diet and exercise. Another option is medication, and the third is bariatric surgery. And I'd like to hear from each of you, first Bob, then Debbie, about how, Bob, to start out, how do you advise patients and how do you suggest which way to go for patients?
Well, when we talk about treatment, when I talk about treatment with patients, Neil, I actually, after taking a full obesity-focused history and get all the information that I need to understand their story and their journey, my first comment about treatment is I go over the continuum of care. It's not a whole, visit to do that, but I start off with that we have multiple interventions from lifestyle management to pharmacotherapy to bariatric surgery. I do that for several reasons. One is we have a lot of options available. Obesity, because you're seeing me, or overweight is a serious problem. And we have many options to choose from, and we use shared decision-making to decide where we land. But the other reason I do it is kind of saying, I have your back. If one treatment is not effective, it's not a one and done, sorry, I have nothing else. We have other treatment modalities, and we can escalate treatment if we need to. But based on shared decision-making, where should we start today? That's really how I start my interventions.
Fantastic. Debbie?
Yeah, I think in addition to what Bob said, I agree with all of that. I think one of the things that once we feel like we know where our patients are and what they're open to, and sort of what the severity of their disease trajectory is and what tools are available to them because of that, then I think the conversation becomes really interesting, because part of what we really need to do in obesity medicine is assist our patients with resources. We think about those 5 A's of chronic disease, and we're really good at the middle 3, and we can remember to ask permission, but then do we assist them at the end? And so I think that's making sure that if lifestyle is what you've chosen together, that you're helping them find those resources in their life to manage that. And it's different for everyone. The same with surgery. And I think medicine actually now is becoming the most complex in terms of what the choices are and how you help patients choose. And I teach fellows, and we have something called the 5 C's of choosing an anti-obesity medication. And I think that can help, if that's the conversation where the patient lands, that can help bring that into focus pretty quickly in a visit.
Debbie, you left a teaser out there. You said the 5 C's. I have to ask.
Okay, good. So no one listening will be surprised that the first C is coverage. So what do our patients have access to? The second is, as healthcare providers, we do no harm. So what are the contraindications, and take those medications off the list. Number 3 is comorbidities. Where can we get double duty? If the patient has diabetes and obesity, then let's go after a GLP-1. If they have uncontrolled depression and obesity, maybe we go after bupropion and naltrexone. Number 4 is cues. What do the patients tell us ahead of time? What do they tell us when they're on the medication? And then finally, as Bob alluded to, a continuum of care that includes combinations of all of those things. So coverage, contraindications, comorbidities, cues, and combinations.
Debbie, I love that. That is really memorable and helpful. Let me ask you something, Bob. As we talked about that continuum of care, it seems to me a lot of people come in now already having tried many times an approach to lifestyle modification. They come in expecting at least medications at this point. How do you convey to them, and how important do you think those basic fundamentals of lifestyle modification are, even as we're advancing to medicine?
Yeah, well, first of all, the presentation has changed over the years. And now they're coming in wanting access to more highly effective medication like the incretin hormones. First thing I do, Neil, is I never say no. You haven't done anything, you can't get it. I have too many learners coming in with this idea that patients have to earn the right for you to bestow a medication to this patient. Like, you haven't tried hard enough for lifestyle treatment, kind of like we would never do for diabetes, right? You haven't tried hard enough to bring your blood sugar down. We think about medications. So I never say you're not a candidate or I don't want to use it. I may say, you know what, you may be a candidate for this medication, but let's really go over what overweight is all about and the role of a comprehensive lifestyle program. It still comes down to, how do you live your life? What are you consuming? The amount of food, the quality of the diet, the amount of physical activity you're getting, including exercise, reducing sedentary time. How's your sleep, stress, social connectiveness? All those factors are important. So when I go over that with them, again, Neil, using shared decision making, what is the best thing for you today? And it may or may not be starting a medication today.
Yeah, I think it's so important. I think that one of my fears has been that we jump all the lifestyle modification and just talk about medicines, and it's an and, not an either or. That we know that if someone is eating less on one of the incretins, it's still in their interest to eat healthy, lean protein, clean eating, whatever that pattern might be, not less of Twinkies and donuts. Debbie?
Yeah, and I think what I would add to that is lifestyle is so important, those basics, nutrition, physical activity, stress, and sleep. But Bob hit something really important, and that is that you don't have to be achieving perfection at that to start or stay on medication or have bariatric surgery. And so I tell my patients all the time, can you stamp an S on what you're doing? Is what you're doing sustainable in your life? Because then we will stick for the long haul. And if they tell me it's not sustainable, then we need to find something that is.
That's so important, creating habits. And habits take a long time. They occur slowly, but then they stick. Debbie, let me shift to another question that I get asked a lot, which is, once you start a medicine, and patients ask this all the time, and clinicians ask this all the time, will people need to be on that medicine for the rest of their lives? Your thoughts?
Well, I think we can start with some data. And I think that is the most common question I get asked by patients and colleagues. And so we can look to some of our common trials. Bob was involved in these trials as well. Step 4, Surmount 4, where we put patients on a medication. The study ended, the medication was stopped, and then we follow what happens after. And on average, remember, studies look at averages, people regain weight. But there's a study underway that I think is going to help us answer that question. It won't be completed until, I think, January of 2026, but it's called Surmount Maintain. And it looks at tirzepatide and putting patients on the medication for a full year. Everyone's on medication, open label, they know what they're on. Then at the 1-year mark, they get randomized to either stay on what their max tolerated dose is or be reduced to the lowest maintenance dose of the medication or go all the way off. And then we'll follow some of that and see what happens. I think it's going to be just like everything else in obesity care. There are going to be heterogeneous responses in all 3 of those categories, but maybe it will give us some insight into who can get to a lower dose or who can get all the way off their medication. I usually tell my patients when they ask the question, I think the majority of my patients need to stay on the full dose of their medication for the rest of their lives. I think a small percentage in my mind, when I watch clinically, can get to a lower dose. And a much smaller percentage, maybe 5 to 10%, can get all the way off. And that's the number that maybe I'm the most sure about because of thousands of lifestyle intervention trials that show us that only about 5 to 15% of people can lose a significant amount of weight and keep it off. So maybe in that scenario, the medication makes the journey less symptomatic and more tolerable, but the severity of their physiology isn't as high, and therefore they can manage it with the lifestyle intervention. We'll find out together, and we're going to learn every day from our patients about this.
You know, it's interesting, Debbie. You mentioned the average, and I love the way you said medical studies look at averages, and everyone I meet thinks they're not average. And they're right in some aspect or another. But if I remember correctly, in Surmount 4, even at the end of the trial, you all had put in what percent of people still maintain different amounts of weight loss. And a good number of people didn't maintain all the weight loss, but still maintained even 10% weight loss, which is quite significant. Do I remember that correctly?
Yeah, that's right. And I think what we're going to need to understand better in the medication realm is what does this look like in the long term? For bariatric surgery, we have 10 and 20-year data. And that's what will take time to acquire in the realm of taking medications. But we want to make sure, as I said before, even in the medication realm, that what we're doing is sustainable and can help that patient keep that weight off.
So, let me jump in, Neil. So there's a few things come to mind. One is we are thinking of obesity as a chronic progressive disease. So right away our mind goes to, the comparator is diabetes or hypertension. We use long-term medication. Should we think the same way as for obesity? I'm not entirely sure. It really falls under the category of art of medicine right now, what we actually do.
Mm-hmm.
I want to highlight one thing that Debbie brought up, and Neil, you're talking about the trials. In the Step 1 extension trial, as well as the Step 4 and Surmount 4 trials, in which medication was stopped, there's a commonality. The medications were suddenly discontinued in all 3 of those trials. And all 3 of those trials showed a weight regain over the subsequent year in the extension trial and the subsequent months in the other trials. And if we think about people on hypertension, diabetes, or depression, do we ever suddenly stop medication? We don't. We try to find their lowest dose. We wean them. We maybe do a holiday. We see how you do. We offer ongoing lifestyle support for those individuals or mental health for those individuals. So I can tell you definitively, don't stop the medication suddenly because the data shows that doesn't work. But everything else Debbie is talking about, whether it's episodic care, de-escalation, changing to another oral medication, which may be cheaper. That was the first C that Debbie talked about, coverage. Maybe we can find something more affordable off of from a highly effective medication. This is something that needs to be studied. And we will know over the coming years as we get closer and closer to a higher level of evidence other than expert opinion, which is where we're at right now.
Those are great points. You know, the sustainable is so important. And one of the things, because all my patients say, I don't want to be on this forever. And that's one of the ways that I encourage lifestyle changes that, you know, to increase the likelihood, and we don't know what that likelihood is right now, that you'll be able to at least wean down on the medicines. Exercise, critically important. eating healthy, critically important. And then we'll have you on the medicine for as long as you need to be. We'll slowly wean down and we'll see. And I think you're right. We're just learning this together as we go. Bob, can I give you a case illustrating this issue and see how you would approach it? And let's say a patient, 54 years old, has been obese for a number of years, has been on semaglutide for 18 months, and now they come in and say, can they stop the medicine? And I think you actually alluded to the answer here already, but how do you approach this with the patient?
Well, I use this buzzword again, shared decision making. I don't just say it to impress your listeners. I really use shared decision making in everything I do. Most people think of shared decision making for colonoscopy. Do you use fecal occult? Do you Cologuard? Do you use, all these things? What do you want to do? I use this with as well. So I give them all the information up front and kind of reiterate what we said. This is the data. This is what we have if we suddenly stop it. I'll also talk about other trials like Look Ahead, in which there was no medication, but yet a good number of the people who lost 10% of their body weight were able to keep, half of those were able to keep it off for 4 years. So it's not a given or predetermined that you're going to regain all your weight. There's heterogeneity, which we talked about. I'll go over all those options with them, go over values, how long do you need it? We'll say, how's the medication working for you? To give you a specific example, I do all day in practice. I'll say, if you're less hungry, more full, not thinking about food as much, less food noise, you feel more in control. When you stop that medication, it is very likely that all those benefits, or most of them, are going to slowly slip away. And you're going to start being hungrier again. You're not going to be as content. Food noise may come back. You need to be prepared for that. So you have to double down on high protein foods, physical activity, coping strategies, urge surfing, all these things we've learned before, monitoring your diet, monitoring your physical activity, monitoring your weight. So bring up all the behavioral strategies that we know have been successful for decades and apply them and keep vigilant of what you're trying to do. And most importantly, come back and see me. Don't disappear. So we could decide together whether we should go back on the medication or go up on the dose, wherever we land upon.
Great points. Debbie?
I think actually we're going to learn a little bit of this in sort of an unfortunate and unexpected real world experiment. So I'm sure both of you are experiencing this already. Some patients who had good coverage for their medications, and as employers and insurers are evaluating the cost of some of the medications, they're withdrawing coverage for those medications. And we see our patients trying exactly the things that Bob described. So maybe they're stretching out the doses between their medication. They're trying to amp up their protein and their physical activity. And so we're going to learn something. It might not be the way we wanted to learn it, but I think we can learn while we're waiting for trials to do this from our patients that are experiencing it right now. And as Bob said, listen to them and help them engage in all the things that they do have the power to engage in.
That's a really good point. Debbie, I know you are an advocate of exercise. You live what you speak. When you talk to patients about exercise and they say, I want to maximize the likelihood that I'm not going to regain weight, is there a amount of exercise you need to do that's different than our usual 150 minutes a week that we've heard about for years?
Yeah, I think the first thing to recognize is physical activity isn't what drives significant weight loss, although it can help. It can help to the tune of somewhere between 1 to 2 kilograms a month if you're exercising at a moderate level. But you hit the key point, Neil, and that is where physical activity becomes crucial. And I sort of like the word physical activity better than exercise, because for some people, exercise reminds them of trying to climb a rope in gym in 3rd grade and they can't do it. Is when we get to maintenance, it becomes essential. And we know from the National Weight Control Registry that about 75% of people in that registry, which is made up of people who voluntarily contribute to the study, they've lost a significant amount of weight and kept it off for a long period of time. 75% of them do significant physical activity. 25% of them don't, and a very small percentage of them don't do any physical activity. So we know the majority of people need this physical activity to keep the weight off. And the numbers that you asked for, if you look at them, yes, the standard numbers for health are 150 to 200 minutes per week. But for weight maintenance, it looks like it's between 300 and 420 minutes per week. That's a range. It's a big range depending on the patient's response to physical activity. But if you think about it, really, that's just an hour a day, 5 to 7 days a week. So trying to squeeze in an hour, at least 5 days a week. And we spend a lot of screen time, scrolling through Facebook or LinkedIn or Instagram. And I think for many of us, we can find that hour. I think the most important thing to getting to that volume is to start physical activity when you start all the other things that you use to treat obesity and build it slowly over time. Because some of our patients need to start really slow. Some of them can't even participate in walking. I know we're going to talk about arthritis later. They maybe need to be in a pool or physical therapy first. Some people can launch a little faster, but a slow, gradual progression at a pace that makes sense to them. Again, coming back to Bob's shared decision-making.
I think one of the exciting things now about weight loss that has a high degree of predictability now with the medicines that we have is it makes exercise easier. That person who has trouble walking because of knee pain, when you lose 10 to 15% of your weight, suddenly you're able to walk more freely, and that opportunity to increase exercise is there in a real way, has been my sense, where people used to kind of nod, but kind of know they weren't going to really comply. Debbie, let me shift in a different direction to another tough question. And you alluded to this issue. When a patient decides on pharmacologic treatment, but they can't get semaglutide or tirzepatide, either due to supply issues or insurance, how do you handle it? And I'm going to ask you to address two different scenarios. One is initially when they come in, and that's the case. But next, the one that you talked about, how about when someone's been on it for a while and now supply has run out? If you can address each of those in turn.
Sure. So number one, when they first come in and perhaps they don't have access, I think we're sort of in this world right now where GLP-1s are on Good Morning America and the Today Show every other day with something new. And so people have heard a lot and they understand that there's treatment for obesity, but they only think GLP-1s. And that's, as you mentioned, semaglutide and tirzepatide. We have other anti-obesity medications that are effective. They don't have the same quote unquote average weight loss like we mentioned in studies. Semaglutide's about 15% total body weight loss. Tirzepatide's about 21%. But we do have other medications that can get to us on average 12% total body weight loss, and many in that 6 to 10 range. Some of those are very inexpensive from a generic standpoint. So if someone has no coverage, for example, you can build a generic version of phentermine and topiramate typically for less than $30 a month. And so I think there's some real options that still have efficacy. Now you have to do that second step of contraindications, make sure there's nothing that they shouldn't be on when you're thinking of things. But I think there's some less expensive places where we can start. And that's what we were using for 10, 15, 20 years before we had the GLP-1s. I think the environment around GLP-1 coverage is going to shift and then shift back again. And I think the future people will have more coverage at a more reasonable price. It's going to take time. The second thing you alluded to is if someone's on the medication and they lose coverage. Is that what you were asking, Neil?
Yeah, that's happening to us a lot.
Yeah, it's really hard for the patients when they feel like they've finally found something that, as Bob alluded to, not only controls their hunger and cravings, but this food noise where I'm always thinking about food and really gives them efficacy. And it's really daunting to think about they finally found a tool that works and now they won't have access. So I think a couple of things can help. One, try to get as much supply as you can before the faucet turns off. Oftentimes the entities that have maybe covered, employers that have covered GLP-1s and then maybe you're going to decide not to, will give patients a 3-month supply before they actually turn the faucet off. And that can do what Bob mentioned, which is help us stretch things out and lower doses slowly as opposed to immediately stopping the medication. And then I think if you have to wean down off the medication because you can't afford it, we can at the same time be trying to add and ramp up one of those less expensive anti-obesity medications. So I think there's lots of options. I will tell you, the staff, and I'm sure this is true in a lot of offices, are working really hard to find that supply, and it's shifting. In the beginning, we were really struggling to find semaglutide. Now we're really struggling to find tirzepatide. I'm sure it will switch back again. So there are ways to switch back and forth between those medications. But I think you have to have a level of literacy in your patient, sort of medical literacy, feeling confident that they can make those changes successfully. Some people can and some people can't. Some people it gets too complicated. So again, shared decision making.
That's so helpful. So we've covered some really big issues. I want to now go over some practical questions that we get asked a lot about. Bob, what do you tell people as practical hints to mitigate GI side effects that often occur in the first month to 3 months on the GLP-1s?
Yeah, critical question. We learned a lot by conducting the Step 1 trial, which was the pivotal trial with semaglutide, in which we kind of learned, as the train was moving, we were learning how to mitigate the side effects of these highly effective incretin hormones. So what we learned is that you can really substantially, in most patients, reduce the side effect by paying attention to the diet. So that's that medication diet interface that we talked about before. By not overeating and stopping when you're just starting to feel full, reducing highly fat or fatty foods is very, very important. Slows gastric emptying. You're probably double dipping on that because the drugs will cause nausea, part of it from the stomach. Not skipping meals, so don't go all day without eating and causing disordered eating. And do not take the medication on the night before you're going out for a celebration like a birthday dinner or going out for the weekend. Because if you don't have control of what you're eating, you don't know what's in the food in a restaurant, you're likely to be more sick. So the end result is be careful to your diet, reduce the portion sizes, reduce fatty foods, have a meal structure and rhythm that's pretty well controlled, and pick an injection day that you know for the next 24 to 48 hours, you have control of what you're eating and you don't want to be caught feeling nauseated, like you're giving a big speech the next day or going out of town. That can significantly mitigate the side effects. And I worry when prescribers give the medication without any dietary advice, you're going to find your patient flooding your inbox with nausea, diarrhea, constipation. Mostly you're concerned about the nausea and the vomiting, and you're playing catch up at that point. And before you know it, the patient doesn't want any part of the drug because they were really sick. So you can anticipate this by counseling your patient on day one.
Very helpful. I often get asked, are there times where you prescribe an antiemetic if someone's having a lot of nausea?
You can. I don't do that often. I'm not the type of guy, let's give a medication to deal with the side effect of another medication. Chemotherapy, I guess we do that all the time, because of the emetic effects. But I have if I need to, but it's actually pretty uncommon that I'm using an antiemetic with a patient.
That's what I've found as well. I know it comes up a lot and I found the exact same thing. Debbie, any things we need to be aware of and advise women of reproductive age about when starting these medicines?
Super important question. I think the first thing to recognize is currently we have no anti-obesity medication that's approved during pregnancy. And so we want to plan around that. So I tell my patients, especially someone who might be coming from their OB-GYN with PCOS, they're really thinking about wanting to get pregnant, and we need to have a plan in place. And so we talk about you should not be on an anti-obesity medication during conception, during the prenatal period, and during nursing. So there's going to be a window there where we're really going to have to implement some of those things that Bob was talking about in terms of amping up lifestyle intervention in the ways that make sense during pregnancy. That also has to be qualified. I think it's also important to remember that there is one option that maybe your OB-GYN might be comfortable with. It's not a standard anti-obesity medication, but we do use it in that way, and that is metformin. Commonly okay in most people during pregnancy, so that might be an option to help mitigate symptoms. And then I think there's planning preconception-wise, a couple things to keep in mind. The majority of our medications, you probably need to be off for about 4 weeks before starting conception. The GLP-1s, you really need to be off for 8 weeks. We need to get that out of your system and being careful of that. If you are taking topiramate, which is one of our anti-obesity medications, particularly inside the combination phentermine topiramate, but even on its own, that is the one medication that's actually shown birth defects. And so we want to make sure that gets stopped right away should someone inadvertently become pregnant. And then maybe the last thing to remember is we think a few of the medications might interrupt the efficacy of oral contraceptives. And that's because GLP-1s delay gastric emptying, and we worry that it might affect that. So the recommendations around that are anytime you start a GLP-1 or you have to advance in dose, that you use an alternative or additional form of birth control during that time period. If you don't, you should just use it no matter what, so that we make sure you have appropriate coverage. And so I think those are the big things, making sure you stop it in time, making sure that you're being cautious and thinking about planning for conception, and making sure you're stopping the medication well in advance.
So helpful. Bob, I want to shift again to what is kind of a big issue. Can you go over the effect of the anti-obesity medicines on the different body compartments, specifically the effect on lean body mass or muscle versus fat body mass?
Yeah, Neil, it's a good question. We're facing it more and more as we're seeing, we call super responders, and individuals losing a large amount of body weight. I first want to set the stage, though, by saying anytime you lose weight, whether it's volitional weight loss, starvation, through bariatric surgery, pharmacotherapy, or lifestyle alone, you're going to lose not only fat, which is the goal with obesity, but also we call lean body mass, of which a big part of that is muscle. And that's really concerned. So you're going to lose both these body compartments, fat and lean muscle, anytime you lose weight. What we're facing now with these highly effective incretin hormones is that individuals are losing not only average weight that Debbie talked about, 15% or 21% with semaglutide and tirzepatide respectively, but upwards to 25 to even more than that, 30% body weight. And if you have someone who's middle-aged or older, who already is starting off with lower muscle mass, you're going to be very, very concerned about that individual. So we have really very few studies so far. They're called sub-studies as part of these large pivotal trials, no more than 150 to 200 individuals who were selected to get DEXA scans at day one and then at the end of treatment. And it looks as though with semaglutide in a sub-study, they lost about 38% of their total weight loss was lean mass. With tirzepatide, it was about 25%. Now, that's pretty much in the range of what we see with interventions, although 38% is on the high range. That needs to be studied more and more. But the bottom line is, in addition, it needs to be studied more, is it appears, at least to me, that the weight loss is not driven by some GLP-1 effect itself, independent of weight loss. I think it's because they're so effective in causing weight loss, and individuals may not be engaging in the physical activity Debbie talked about, including resistance training, and they may have been older. They're really losing quite a bit of muscle mass, and we're very concerned about that.
Great point. Debbie?
Yeah, Bob mentioned some great numbers, which I think we also knew similar numbers from bariatric surgery because of the rate of the weight loss that Bob referred to. And I think it's interesting that as a field in the bariatric surgery world, they've said, okay, typical muscle loss is between 30 and 40% of the total body weight loss, and just identified that as something they'd observed and decided that that was acceptable. And I think now we're understanding that's not acceptable. We can try harder. And I can share with you in clinic that, when we do the things that Bob mentioned, increase protein, increase strength training in particular, and in a patient who perhaps is losing weight really quickly, maybe consider mitigating the trajectory a little bit, maybe turning down the dose of the medication to slow things down a little bit if it's just too fast. I find in clinic that we can keep people to about 0 to 10% of their muscle loss is of the total body weight loss. And it's rare that I find people that end up in that 20 to 30% when they're doing these simple lifestyle changes that Bob referred to. So with some great education, they can manage it. And I also want to encourage my primary care colleagues that you can monitor this. There are inexpensive body composition machines that once you purchase them for your clinic, it's really just the cost of paper to keep it going. And you can be able to see what's happening in the muscle mass for your patients, in addition to just what's happening on the scale.
Briefly, those body composition machines, what type of machine is that?
So they're called bioelectrical impedance machines, and they use electrical currents, which go through tissue and come up against resistance, and that helps them decide whether something is muscle or fat or bones or organs, and that's based on the hydration of the cell. And the thing that I like about them is even though they might not give us the true number, if we'd done a DEXA scan on a patient, they let us follow for trend to see what's happening with that muscle. Now, it is interesting that there's some more recent data out that looks like we might need to look more carefully at how close those correlations are. And it might be worthwhile in the future to get a DEXA scan for body composition in the beginning, and then maybe a year down the road when there's been significant weight loss. The bioelectrical impedance machines, I do at every visit with my patients. So they're getting it, at least 6 times a year.
Debbie, quick question on those, because I know you can get some on Amazon for about $20 that you step on them like a scale. There are others that you have to use your upper body, hands around it. I assume those are better because it goes through the whole body. Is any brief advice there?
Sure. So yes, patients can buy very inexpensive versions of this to have at home. That's not necessarily bad, and they can follow it for trend. The difference is at home, it's a single electrical frequency. And so the farther away you get away from a quote unquote typical body shape in a normal BMI, the more erroneous the numbers can be. In clinics, the machines that we buy typically have between 3 and 5 frequencies, and research machines typically have 7 frequencies. And that lets us get more accurate data. And as you mentioned, as opposed to just holding something or stepping on something, you're doing both. So it can separate arms from visceral central fat, which is what we're most concerned about from a cardiovascular risk standpoint.
So helpful. So to mitigate that muscle loss, it's lean protein, it's resistance exercises in addition to our usual aerobic exercise that we think about. Bob, any other things we need to think about when we specifically think about treating older adults? I am not going to give an age here. We know that is over 50, maybe over 60. I'm not giving an age.
Yeah, thanks, Neil. It's a very important question as more and more individuals are seeking help and have these complications and comorbidities. We're often getting to group with multiple morbidities. So we're getting to individuals who are older. So a few things come to mind. To really work off of what Debbie and you were just talking about body composition at the end here, we also want to think about function, and that really is what it comes down to. In all of the trials we've been talking about, they've used patient-reported outcomes, PROs, and if you use the SF-36, this health outcomes thing, its physical function is the one that stands out, that improves when you go on these drugs. And we think there's a correlation with holding on to muscle mass, but we're not sure. That needs to be looked at carefully. But that's a direct lead into the elderly or the aging individual, in which they may start off with lower muscle mass at the beginning of treatment. And if they lose a lot of weight, they're going to lose a lot of muscle mass. They could end up with, which is called sarcopenia, or even sarcopenia obesity. It means their body composition is inappropriately low in body muscle and lean body mass. That is particularly concerning in the older individual, where mobility, being able to get up, function, carry a grandchild, carry groceries. If you slip off a curb, you don't fall and break a hip. Very, very important. The other body composition area that's important, particularly in this group, Neil, is bone. We know that as you lose a lot of weight, you also lose bone mass. And if you take an individual, to say a postmenopausal woman, go on these highly effective drugs, it may escalate the loss of bone mass, developing osteoporosis. So in addition to muscle loss, you can get bone loss. In addition to taking extra protein, now we're talking about calcium and vitamin D in these individuals. So those are the things. And you also mentioned one last thing is osteoarthritis. So I think Debbie mentioned osteoarthritis. In the aging population, we have a lot more arthritis of weight-bearing joints as well as non-weight-bearing joints. And if we're going to be talking about getting the amount of physical activity in someone who's losing muscle mass, losing bone mass, but now you have to get in 400 minutes of physical activity. Not impossible, but you really have to work with the patient very carefully, do no harm, and increase their vitality and muscle function.
Great points. Debbie, any other pearls as we're getting toward the end of our podcast about the use of GLP-1s and GIP-GLP-1 receptor agonists that you want to share with our audience?
Sure. Bob mentioned that sometimes we do analyses of big trials after the main question has been answered. And there's some things in those trials that can help us understand how our patients respond. So in general, women lose more weight than men on these medications. So in my mind, that makes me think in my male patients, I might have to get to a higher dose. In general, people with a normal blood sugar lose more weight than people who have prediabetes or diabetes. So sort of setting that expectation for yourself and the patient. I think whether it's GLP-1s or older medications, we see that the majority of the weight loss comes in the first 24 weeks, and then it continues to about a year, but at a much slower trajectory. And that's the normal response to the medication. So helping our patients understand that, so that when they get to that place and they're about 6 months in and weight loss starts to slow down, it's not that the medication isn't working anymore. It's that they're getting close to the efficacy that they're going to get from it. And then along the lines of that, knowing that about 80 to 90% of people get to their plateau by 1 year. And a plateau is not a bad thing. It's, again, just the efficacy of the medication. And if you're not where you want to be and your patient's not where they want to be, then you think about what other things can we change or add on to get closer to the target that you had in mind. But I think those are some of the things that help patients frame what they should expect, and we'll learn more in the coming years.
So helpful. We've covered a lot of ground, and there's no question that treatment of obesity has emerged as one of the most promising and exciting areas right now in primary care. I want to just spend a few minutes sharing some of the excitement about what's still in the pipeline, what's coming up. And Bob, can you share with us a little bit about that pipeline, exciting things that we have to look forward to with regard to weight management?
Well, these highly effective medications we currently have come about because the target for obesity has changed, and these are called gut hormones. So all the exciting medications that are emerging, and Debbie's still involved in helping to run a lot of these trials, are combinations or dual or triagonists of these gut hormones. So it's kind of like playing chemistry of how do we combine them in what dose and what can we get. But I do want to mention a few. One is the combination of semaglutide, which we've talked about, along with cagrilintide called CagriSem. Debbie's, I think, involved in one of these trials. Bringing both of these together, and you're seeing a weight loss of 15% or so in 32 weeks. These are individuals with diabetes, although the trials are now going on with obesity itself. These same gut hormones, which are peptides, one's called a triple G, which is retatrutide. So it's a combination of GLP-1, GIP, and glucagon, these gut hormones. And that had a 24% weight loss at 48 weeks. These are mind-boggling numbers. These are phase 2 trials. Mm-hmm. These same gut hormones, which are peptides, are now being made into small molecules that could be taken orally. One is orforglipron, another oral GLP-1 with a weight loss of nearly 15% at 36 weeks. And the last one I want to mention, which is a whole different target, and that is under the category of muscle-preserving pharmacotherapy, right? So in addition to resistance training, of course, we're going to get someone to be more active and lift weights and get in the 300 minutes of aerobic activity a week or that type of thing. We are now targeting the muscle. And I think everyone's heard of cytokines and adipokines, right? These are these mediators from either immune cells or from fat cells. Well, myokines are signals that come from muscle. Whole new biology to most people, identified only about 20 years ago. So there's now another medication called bimagrumab, where it's a whole new vocabulary test here, which targets a receptor of myostatin, which breaks down muscle. So if you block the breakdown of muscle, you can then have muscle hypertrophy and the growth of muscle. And that one is also being investigated. Wow. And the last one is selective androgen hormones that don't have this testosterone effect, but have a muscle building property. So really, really exciting arena coming up of emerging drugs over the next several years to probably a decade or so.
This is very exciting. This is why all of our colleagues really have to learn now about what's going on, because there's going to be so much more to come. Debbie, I know you're involved in a lot of trials, and there's a lot going on. We saw recently the SELECT trial with semaglutide, a 20% or so decrease in recurrent vascular events in people with obesity and existent ASCVD. I heard recently about a trial on tirzepatide and OSA. Can you let our audience know a little bit about semaglutide and tirzepatide and some of the trials that are in progress now in that area?
Sure. So I think this becomes really important in the primary care world because you're trying to treat things efficiently, effectively in a small amount of time with your patients. And I think some of what we're seeing in these secondary trials are the opportunity to get at multiple comorbidities in addition to obesity. So Select, probably the biggest splash in the last year. I was one of the investigators. Bob was one of the steering committee members. Just a really important trial that showed 20% cardiovascular risk reduction. So when you think of semaglutide and multiple targets, you can think of who is my patient with coronary artery disease, a previous heart attack, a previous stroke, peripheral arterial disease. They will benefit not only from the weight loss and perhaps glucose control, but also lowering their cardiovascular risk. Some of the other fun trials that are going on, you alluded to the osteoarthritis trial with tirzepatide. And what they demonstrated is a 20% reduction in pain for those individuals with osteoarthritis when they could get their weight down with semaglutide. I think some of us have questions about, is that both for arthritis and cardiovascular disease only the weight loss, or is there something anti-inflammatory about these GLP-1s that gets at this really base root cause of a lot of disease states? There was also a recent trial published with tirzepatide that looked at sleep apnea. Affects a lot of people in the United States, especially individuals with obesity. And it showed it was able to reduce their apneic events by 2/3, which creates a much better night's sleep, which we know lowers stress hormones and allows their body to function in a better way. And I think we're just going to keep seeing these trials. It's being investigated for MASH, the new name for NASH. It's being investigated in things like alcohol reduction intake to see if it can also treat people who struggle with alcohol, because we found just watching patients in the trial that alcohol is less interesting to them. And so maybe that's something in this craving side of the brain that's working. And I think we'll see more of these line up. And I think it's encouraging. I don't think any medication should ever be considered a panacea, but I do think it provides an opportunity to get at comorbidities, that third C in the 5 C's, to treat more than one disease at one time. And in the primary care world, that's really important because we want to be efficient, effective, and time effective.
That is for certain. Speaking of time, we are about out of time. Bob, any final thoughts that you have for our listeners of the podcast?
I do. First of all, I thoroughly enjoyed this with you and Debbie, so thank you so much for inviting me. I want to highlight or emphasize that everything we talked about tonight, as exciting as this field is, will be no more than an academic exercise unless our primary care prescribers develop the comfort, familiarity, and competence to treat obesity at that primary level and to utilize anti-obesity medications when indicated. So please take every opportunity to educate yourself, to talk to your local champion, listen to this podcast, read wonderful articles coming out, and stay involved and proactively treat your patient.
So agree. Debbie, your thoughts?
I think I'll just keep it simple. I think as Bob said, we cannot win this war on obesity with just the obesity medicine docs and the endocrinologists. We need our primary care to treat just like they treat diabetes, to start treating obesity. I love the beautiful things that Bob mentioned for getting more education. And I would encourage you, he mentioned a champion. Find someone in your community, whether it's another primary care physician who has a big interest in obesity and is already treating a lot, or an obesity medicine specialist or endocrinologist, and spend some time with them if you can. Or an easy thing to do is refer a couple of patients to them. They're going to send them back to you, and you're going to learn what happened and what that pathway was like, and it'll help you feel more confident in doing it yourself.
What great suggestions. Doctors Debbie Horn, Bob Kushner, thank you so much for joining us.
Thank you.
Thank you, Neil.
And to our listeners, most importantly, thank you for joining us for this 4th episode of our 4-part series on obesity, sponsored by Novo Nordisk and Lilly. If you haven't listened to the first 3 podcasts, I highly recommend them. They are really good. They are filled with practical information, background information, all of that. For the American Diabetes Association and the American Academy of Family Physicians, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.